So may I have your attention, the esteemed faculties and delegates? Now I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the localization assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation. Now, the focus of today's session is what's new in LA Strain. To start with this Sunday TE session, I would like to present before you a short welcome video. So thank you everyone for all your patience. So now without any further delay, I would like to hand over the session to Dr. Poonam ma'am to start the event today with her enlightening words and for the further coordination. So over to you ma'am, kindly proceed.
Thank you, Ritupurna, and thanks a lot to Clarinet, to Dr. Muralidhar, to Rajiv, who's at the backbone of all these Sunday TE sessions for the last 10 years, and to all my cardiac colleagues, whether surgeons, anesthesiologists, intensivists, and all fellows who are with us, joining us for this Sunday TE. It's important that you know what happens when there's deformation. Just as there is a stress deformation and there is a strain on the muscles of the body, so also in the heart. The global longitudinal strain is a very, very pertinent established factor to tell us about both the systolic as well as the diastolic function of the heart. But what about other chambers of the heart? The LA, the RA, the RV strain in transthoracic echo have just come up in a very, very established way. And in recent times, the British Society of Echocardiography has come out with a very pertinent guideline itself on LA strain. A lot of work at our center at AIMS is going on between comparing LA and RA strain perioperatively as well as postoperatively to give a prognostication and risk stratification in heart failure patients who have a preserved ejection fraction, as well as whether they will be more prone to an atrial fibrillation, a thromboembolic event, the increase in LV filling pressures, and a host of other prognostication and risk stratifications. So today, LS strain stands established as an important guideline factor and an important parameter for diastolic dysfunction of the heart. And who better than Dr. Deepak Borde to tell us the details about this LA strain? Dr. Deepak, as a consultant and a senior consultant in charge at the Ozone Hospital in Aurangabad, stands tall as an IACTA member I've known him for over 20 years. Started as an IACTA fellow with us, won many awards like the Janak Mehta and the IACTA Best Trainee Award. Went on with his best friend, Dr. Sridhar Joshi, to write great articles and did good fellowships in Leipzig and other places when he came back and started echo and research papers on transmitral velocities with E-septal separation and a host of other small and big ET tube related research topics, which won him many acclaims and many awards nationally and internationally. I'm so proud as a mentor of his to be hosting him as a speaker today. Having worked at length last 10 years in ECHO and as a past president and editor of IACTA, it's very, very good. And I hope all future fellows follow some speakers like Dr. Deepak Borde. I'm so proud of his journey as an academician, as a researcher, as a consultant, and as a performer. So over to you, Deepak, who will be telling us today about what's new in LA strain. And thank you, Dr. Mullidhar. I met you at EuroAsia and good to see you back there. And thank you for this opportunity to host and moderate the LA strain with Deepak Borde and yourself. Over to you, Deepak, to begin your session. Dr. Mullidhar would be giving us a few words.
Hello, good morning. Can you hear me?
Yes, we can. Yes, we can.
Yes, thank you so much. I'm really delighted and grateful for both Dr. Poonam and Dr. Deepak Borde for having consented to be with us this morning for the Sunday breakfast with TEE and echocardiography. This has been going on for the last 3 years, regularly on Sundays between 9 to 10. Thank you so much for the support from the Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiologists, Global Heart Care Foundation, and the International Society of Cardiac Ultrasound. With these few words, I would like to hand over back to Dr. Poonam Malhotra for the excellent opportunity to know about the recent advances regarding the left atrial strain, which is an upcoming topic now. And please put your questions and comments in the chat box. We'll get back to you at the end of the session. Thank you very much once again. Back to Dr. Poonam Malhotra.
Thank you, Dr. Mullidhar. Without much ado, we'll hand over to Dr.
Yes.
Deepak for telling us about what's new in left atrial strain. Over to you, Deepak.
Good morning, everyone, and hope my slides are visible there. A big thank you to everyone, and it is a great honor and pleasure for me to present something in front of great echo teachers, Dr. Poonam Madam, Dr. Murlidhar sir, and thank you IACTA, IACTS for giving this opportunity to share a topic which is not really a TE, but upcoming topic which all of us should know what's new in left atrial strain. So the outline for today's 25-30 minute talk will be left atrial mechanics, how we can evaluate the left atrium, the diastolic dysfunction, what is the importance of diastolic dysfunction. There was an unmet needs for the last 7 or 8 years when 2016 American Society of Echocardiography published their guidelines on comprehensive assessment of diastolic dysfunction. It has been a while for that, and now a lot of new research has come up, particularly in left atrial strain. And as was expected, the 2024 guidelines by British Society of Echocardiography, probably the latest one published this month only, they have included left atrial strain in the comprehensive assessment of diastolic dysfunction. So probably some of us, you may not be doing left atrial strain on a regular basis. So just a quick introduction on how to do the LA strain. Then we will again go over on the evidence part of it, particularly in 2 areas which are very relevant for us as cardiac anesthetists and cardiac surgeons and cardiac intensivists, that is left ventricular diastolic dysfunction, how LA strain is useful, and a new area which is coming up is prediction of post-operative AF. So I would be briefly discussing our recent paper that we have done. So, and finally, we'll conclude with take-home messages. So all of us will agree that left atrial volume is one of the very important markers of adverse cardiac events. But these indexed volumes were later introduced, and they are considered like HbA1c of diabetes. Same value is given to left atrial indexed volume. But as we kept on evolving, we know that there is something more important than left atrial volume. Because at times you have got large left atrial volumes, but they are functionally very normal. Like particularly in athlete heart, they may have a big left atrium, but their left atrial function may be normal. Or some of the acute events which might happen. And in that case, the left atrial volume may be normal, but there's significant amount of left atrial dysfunction. So there are basically three components of left atrial assessment, and that is reservoir function. That is when the left atrium gets filled during left ventricular systole. Then there is an early emptying of the left atrium, which is labeled as a conduit function of the left atrium. And finally, the pump or the contraction function, which is due to last atrial kick, which happens for the contributing to the last 20-25% of the stroke volume. So this left atrial contraction usually corresponds to the P wave on the ECG. So here is the demonstration of the three important aspects that we can do. So this is left atrial volume in the center. So this is EF, meaning a emptying function, not ejection fraction. This is emptying fraction. So emptying fraction for the reservoir function is maximum left atrial volume divided by the minimum left atrial volume, which is there after the contraction. Okay, then the pump function of the heart is usually corresponds to the P wave on the ECG, which I told. So this is A minus B divided by A. So this is a pump function, and a passive feeling which happens in the early diastole, that is emptying fraction passive. So these are the three important volume indices: emptying fraction active, and emptying fraction passive, which are assessed by left atrial volume. So coming to left atrial strain, similar three components: the reservoir function, which is the maximum left atrial strain, which happens at the time of left ventricular systole. So when the left atrium fills in maximum. The pump function, which is due to the active contraction of the left atrium, and the passive function, which is in between the peak left atrial strain and active strain. So in between is this left atrial passive strain. There is another important parameter which is not well studied, not very greatly evaluated, but still very important, with the left atrial strain at the time of contraction of the left atrium. So all these three important parameters are used to assess the left atrial function. So coming back to this basic cardiac cycle, in which this initial part is because of the left atrial filling. So this is pressure, LA pressure. So the left atrial pressure slowly start building up. Then there is passive emptying, which happens at this green part of the graph. Then there is a period of diastasis, which is with this dark blue part of the graph. And then there is active emptying, in which the LA pressure again increases. And then finally, there is left atrial relaxation. So as I told, there has been recently tremendous increase in understanding of left atrial size and function. And I request everyone, particularly those who are in training, to read this excellent series of articles, which are basically results of World Alliance Society of Echocardiography. This has been a groundbreaking research across 20 different countries in all continents. They have taken more than 2,000 patients across these 20 countries, evaluated various parts of the heart, their sizes, their function, their overall evaluation. And they have come up with at least 12 or 13 different papers on the normative values using both two-dimensional and three-dimensional measurements. So So they have given 2D LA measurements, 3D LA measurements, and 2D LA strain measurement as the normative values. These were the healthy population. And as you can see here in the bracket, that the normative value of 2D left atrial reservoir strain is around 42 plus or minus 10. Then the conduit function is usually 27 plus or minus 10. And the booster or the left atrial contraction part, which is around 15 plus or minus 6. So these normative values have been described for either sex. There are some minor variation in men and women, which are not very, very different because there are various differences in the volumes, but not so in the function. So functionality we are assessing with the left atrial strain, and the normative value remain more or less same in men and women. So coming to this part, which we always deal in perioperative period, diastolic dysfunction, and why it is important. Because all of us know that a patient with advanced diastolic grade has got higher chances of adverse outcome after cardiac surgery. A patient who has got an elevated left atrial pressure, which is essentially left ventricular diastolic dysfunction grade 2 or grade 3, they may have a higher risk of adverse events after cardiac surgery. And this has been assessed all over like CABG patients or AVR or combined surgery. Irrespective of the surgery, the diastolic dysfunction grade in this particular paper was adversely associated with after cardiac surgery. And the ejection fraction was not essentially a very bad factor. But if you have both systolic and diastolic dysfunction, like in this particular paper, which is from Canada actually, and they have said that those who have got ejection fraction more than 35 and the LV-EDP less than 18, that is a diastolic dysfunction probably grade 0 or grade 1. So they have the highest chances of long-term survival. So this survival was seen even up to 8 years after cardiac or after a CABG surgery. And those who have got a systolic dysfunction and a diastolic dysfunction, they were remarkably, their survival was lower, as good as 50% that of the group 1. So then the question comes in, how do we actually assess the left ventricular diastolic dysfunction, and how do we grade that patient has got a higher left atrial pressure? So this has been done by echocardiography since last 2 or 3 decades. And there have been various attempts to make the guidelines and to give a particular grade of diastolic dysfunction, but this is not an easy task. So there are multiple parameters involved, and those who are in the beginning phase, they may get bogged down by these various numbers. So there are various numbers to follow, and the most important limitation of this guideline was there are a lot of patients who were getting classified in the indeterminate group. Like the guidelines say that, okay, we cannot assign a particular grade of diastolic dysfunction for this particular patient, because many times you get 50% out of 4, 2 are matching and 2 are not matching. So in what to do? So even in patients with LV dysfunction, there were various parameters which we needed to assess, and then finally it came to the conclusion that we cannot determine. So this algorithm, which is American Society of Echo Algorithm 2016, is a complex, time-consuming algorithm. It had multiple parameters. It needed multiple tissue Doppler, continuous wave Doppler, pulse wave Doppler, various parameters needed to be assessed. And even after this entire exercise, there were significant patients in indeterminate grade. So another important limitation of this guideline was that they are very explicitly stated that these guidelines are not focused on surgical patients. So there is an unmet need for certain parameters to guide quick assessment of LVDD and LV filling pressure, more importantly, filling pressure, to assist with decision making. So probably a step forward has been put, and I'm sure that recent American Society of Echocardiography guidelines are also on the way. But by the time we have this 2024 guidelines, which are published this month only, about assessment of LVDD by British Society of Echocardiography. These were much awaited. I think last year in the British Society of Echo meeting, they had released this guideline, but officially they have come up in this month. So what do these guidelines have new to say? So these guidelines again are following similar path that of AAC. That is, they have divided patients in normal LV systolic function and abnormal. So first you need to assess normal LV systolic function. You need to establish that there is normal ejection fraction or normal global longitudinal strain. Then you quickly do 2 or 3 parameters. 3 parameters here. That is E by E prime. That is average value, septal and the lateral, the left atrial volume, which is very important, and TR velocity if it is more than 2.8. So out of these 3, if you have got 2 or 3 positive criteria, then straight away patient goes in impaired diastolic function with elevated filling pressure. So 2 or 3 positive criteria, straight away patient goes for grade 2 or grade 3 diastolic dysfunction, that is with elevated filling pressures. But at the same time, if 2 or 3 criteria are negative, straight away you have got a normal LA volume, you have got a normal E by E prime ratio and not much of TR velocity TR, then straight away patient goes for a normal diastolic function. So that is grade 0. What happens in between? So if you have got only 2 criteria which are available, many times you don't get a TR velocity. At times you may not have a full LA which can be visualized like in TE. So what you do then? In that case, you do a left atrial strain. And these are probably the first guidelines which have incorporated left atrial strain. So how do you incorporate that? You first assess the left atrial strain. You say that the reservoir strain and the pump strain. So if the left atrial reservoir strain, if that is less than 18%, then you have got a very high probability that this patient will have a high left ventricular filling pressure. So if you are not getting all the criteria, then you go for left atrial strain and then you can divide the patients as grade 1 or grade 2 or grade 3 diastolic dysfunction. So if you are not sure, then left atrial strain comes for you in your rescue in case of normal LV systolic function. What happens if there is LV EF less than 50% or a global longitudinal LV strain of less than 16%? Or if the patient is a known myocardial, like somebody who is already having a coronary artery disease. So here you again assess this 3 criteria and same path is followed for if there are 2 or 3 positive criteria, then you straight away go for impaired relaxation with high LV filling pressure. If there are only 1 criteria which is positive or all the 3 which are negative, then you go in the phase like impaired diastolic function with normal LV filling pressure. So probably these patients will have a grade 1 LV diastolic dysfunction. In case you are not able to clearly get all the 3 parameters, you get only 2. One is positive and one is negative. Then again you assess the left atrial strain. So if the left atrial strain is less than 18 or then you straight away go for higher LV filling pressure. If the left atrial strain is still normal, if it is more than 24, then probably you need to assess various supplementary parameters which they have mentioned. One of the most important being the AR minus A duration. In this, the AR is the A wave duration in the pulmonary venous Doppler minus A wave duration, which is during the mitral inflow. So AR minus A duration, if it is more than 30, if there is L wave present, which is more than 20 centimeter per second, if there is deceleration time, which is less than 150, okay, or if the pulmonary venous S wave is smaller than the D wave, then probably you have got patients with higher filling pressures. So that is how left atrial strain can help you. If the evidence is equivocal, okay, that was the indeterminate group in the earlier guidelines. So if you have got something which is indeterminate, so you go for left atrial strain. If the left atrial strain is lower, then straight away the patient goes for high filling pressure. If the left atrial strain is reserved, then patient goes for normal LV filling pressure. If it is in between, then you need to probably assess more parameters. That is what this British Society of Echo guidelines have stated. So these guidelines have stated another important parameter, like there are various important prognostic factors for pre and post capillary pulmonary hypertension. So pre-capillary essentially has got a normal LV filling pressure. So in this case, you go for a left atrial reservoir strain. If it is more than 16, probably you are dealing with a pre-capillary pulmonary hypertension. If the left atrial strain is less than 16, probably you are dealing with a post-capillary pulmonary hypertension. So this guideline again is very useful. This is from the same British Society of Echo guidelines in differentiating between pre and the post-capillary pulmonary hypertension. The role of left atrial reservoir strain has been emphasized here as well. So as I told, not all of you will be familiar. So I'll just show a quick video on how to do a left atrial strain. This is basically taken from this EACVI and AAC guidelines. Various industry inputs have been also put in standardizing this criteria. So how do you do it step by step? You select an LA focused view, which is non-foreshortened for the left atrium. You narrow an image sector, or newer softwares need not narrow this image sector. You check for artifact, then acquire 3 to 5 consecutive beats. Then you contour the left atrium using an automatic feature. And I would like to say here that almost all of the vendors have now come up with specific left atrial strain software packages. Like GE has in their EchoPack version 204 and the latest 206 has a dedicated left atrial strain. Earlier, we were extrapolating the left ventricular strain into left atrial strain. But now these latest softwares are available. Even in Philips or Tomtech, they have gotten dedicated LA and RV software which are available. They are still in a phase of giving it to the right atrium. But as Madam said, that a lot of research is coming up on the right atrial strain as well. So probably in next few years, we will see a dedicated right atrial strain software also. Okay, so coming back to this, we need to adapt to a contour, and we need to just report a left atrial strain in all the 3 components. So here is the 4-chamber. So this is how the 204 version of EchoPack looks. You have got an AFI LA, and you choose actually 3 points from this. One is a lateral, septal, and LA roof, all the 3 components. The machine will automatically contour it. If you are not happy with the, you can actually override on it. Then from 4-chamber, you go to 2-chamber. Again, you do inferior, anterior, and the LA roof. You approve or you modify it. And I think within 15 seconds, machine gives this values. So you have got a 4-chamber reservoir strain, conduit, and contractile strain, or a booster strain. Okay, so this is for the 4-chamber. Then similar values for the 2-chamber. You get the left atrial maximum volume. If you are having a 3D probe, then probably all the 3 volumes of the left atrium, which I discussed in the initial part, you can get it here. But this is also equally good. And finally, you get average values, that is left atrial strain, reservoir average, conduction average, and contract. Okay, so this is not very difficult. If you have got a software, this is just a 30-second exercise. So coming to utility of left atrial strain in diastolic dysfunction. So this was a great paper by Professor Roberto Lang and colleagues. And they have said that as the diastolic dysfunction grade worsens, you get lower left atrial strain. So there is a serial reduction in the left atrial strain as the diastolic dysfunction grade worsens. So in the gray here is the grade 3 diastolic dysfunction, which is represented here. And the light blue is the normal left ventricular diastolic function. So as you can see, as the diastolic dysfunction grade worsens, the left atrial strain reduces in a serial fashion. So this is very important. So same group actually has said that you can assess, you can use this left atrial strain as a single measure of non-invasive assessment for left ventricular filling pressure. So they assessed around 150 patients, I think. They invasively measured the LV-EDP during a cath procedure. They did extensive diastolic dysfunction assessment, comprehensive assessment, and then they did a left atrial strain assessment. So as you can see here, the LV-EDP is 9, which is absolutely normal, and you have got a normal left atrial strain. So in this another patient, the left EDP is 19, which is clearly elevated, and you have got a very low left atrial strain. And if you have got something, you are unable to assess TR. So this is an indeterminate category of patients. And what you see is the left atrial peak strain 30, which is near about normal. So what they got on a EDP was 5. So this category, this was a earlier paper, 2019. So this indeterminate category could be very correctly resolved with the left atrial strain. Then there was this Italian group led by Matteo Camelli, and they've said that for the filling pressures, the left atrial strain was far more superior than E by E prime ratio. A lot of emphasis in perioperative period we give about E by E prime ratio, but we all know that it is only a moderately sensitive parameter for assessing the left ventricular filling pressure. In contrast, this left atrial strain was very highly significant criteria with an area under curve of 0.92, which means almost equally correct. So left atrial volume was again a good criteria, but best was left atrial strain. So this particular paper actually differentiated various ejection fraction wise. So if you see here, E by E prime ratio was not very useful in patients who have got a low ejection fraction. So in those patients, actually, it is very crucial for us to know if the filling pressures are high or not. So as to adjust our perioperative therapies, like how much fluids we should be giving, how much diuretics we should be giving, and other parameters. So how much nitroglyceride to be given to those patients. So these are very important patient category, but unfortunately, E by E prime ratio does not perform well in patients with severe LV dysfunction. But in contrast, patients who have got different stratified different ejection fractions categories, but still the left atrial strain was very, very useful parameter for left ventricular filling pressure. This was again a similar paper in which they've said that E by E prime ratio is having only area under curve of only 0.6 or something. But consistently for all the studies, if you see various parts of the world, they've said that the left atrial strain actually has got excellent area under curve for LV-EDP mutual. How it can be useful in perioperative period. So this was a very good, actually it was a case report, but they have discussed it in great details. The patient came in a very congested state, probably very high PA pressures, a mean PA pressure of 67, CVP of 19, patient having grade 3 diastolic dysfunction. In a patient came in very bad shape. Obviously, his left atrial strain was only 5.02%. So you started treating this patient, you started decongesting this patient. Slowly, the PA pressure came down from 67 to 31, CVP also settled. At the same time, the left atrial strain increased from 5 to 12. So you can serially monitor. And after 6 weeks, this particular patient has got almost a normal left atrial strain. So you can serially monitor this patient after giving certain therapy. So that is also utility. So this graph is very, very essential. What does this graph tells is the limitation of all the current measurements that we have. We all know that there is a bimodal presentation of E by A ratio. So E by A ratio reduces in grade 1 diastolic dysfunction starts increase, it becomes pseudo normal in grade 2, and it increases significantly at the advance. So if you have got a normal E by A ratio, you are not sure whether you are in normal phase or a pseudo normal phase, that is grade 2. So that is the important limitation of E by A. So important limitation of left atrial index to volume is it starts increasing only during grade 2. So in earlier phases, it is not a sensitive parameter. Okay. And the E by E prime, it increases early, it increases probably early, and then it remains the same. So it cannot differentiate well in grade 2 or grade 3. That is important limitation of E by E prime ratio. But look at the top, the left atrial strain, it has got a serial reduction as the grade of diastolic dysfunction worsens. So that is the importance of left atrial strain. It can be used as a single parameter. Okay. So with this background, I would quickly walk you through a recent paper that we have published in JCVA. And we have assessed for the left ventricular diastolic dysfunction and elevated filling pressures in patients undergoing CABG. And what we demonstrated here is almost the same thing which the other authors have demonstrated, that there was a serial reduction in the left atrial strain parameters, and the this left atrial strain was having an area under curve of 0.92, excellent area under curve for elevated filling pressure and any grade of diastolic dysfunction. So normal versus abnormal, it could pick up very correctly, and with elevated filling pressure, that is advanced grade of diastolic dysfunction also, it could pick very easy. Okay, so what we concluded was left atrial strain is a single parameter which was significantly associated with grade, and the number which we came, the study which we published in 2021, and our number was 90. And if you remember the British Society of Echocardiography guidelines, they also have given this number of 18. So almost similar number that we could get. Okay. So its utility in the day in and day out practice. So these are the two patients. Actually, they happen to be on the same day. So they were posted for CABG, and post induction, you note a blood pressure of 70 by 42. This first patient is a 72-year-old lady with no comorbidities. Ejection fraction is 62, normal ejection fraction. This patient, 54-year on the right side, hypertensive, is a chronic smoker, again normal ejection fraction. So what you would like to do in both the patients, same treatment or different treatment? So if you have done a left atrial strain, so patient on the left has got a strain value of 32, which is absolutely normal. So you mean that you know that this patient is volume responsive. So as in response to initial hypotension after induction, you would like to give a fluid bolus to this patient. In contrast, the patient on the right, which is a chronic smoker and probably has got larger LA volumes and a lower left atrial strain, which is only 11%, you would not give fluid boluses to this particular patient, and probably you would like to start early on the vasoconstrictor for this patient. So that is the importance of knowing left atrial strain in the perioperative or a preoperative period. Okay, so there have been certain attempts about doing left atrial strain by using transesophageal echo, but they were limited to very few studies, and there was only a moderate correlation between a pre and the intraoperative value. So this is still in the nascent phase. So what is well established is the preoperative assessment by transthoracic, or it can be done in the ICU. So coming to the second area of utility of the left atrial strain for prediction of post-operative care. This study we have completed this year only, and this is under evaluation. That left atrial strain to predict POAF, post-operative AF, in patients undergoing off-pump CABG. We studied around 103 patients who underwent CABG in last year, where we did echocardiography for left atrial strain. The POAF occurred in 23.3% of the patients. And as you can see here, there were no differences in AF versus no AF patient post-operatively as far as the ejection fraction is concerned and as far as the left global longitudinal strain is. So there were no differences in the diastolic function parameters also. But see this left atrial strain measurement, the reservoir strain was significantly lower in patients who had got EF. All the three parameters, conduction and contractile strain, also were significantly lower in patients who developed AF. So a sample patient who had got a left atrial strain of 10% on two chamber and 11% on the fourth chamber, he developed post-operative AF versus patient who had gotten strain value of 26 and 27 did not develop AF. So this can be very, very useful. We all know how notorious post-operative AF is. The patient typically stays for one extra day in ICU. There's a lot of hemodynamic instability. Patients may need higher non-invasive or invasive ventilation, and overall the adverse effect of atrial fibrillation need not be emphasized, because we all know that post-operative AF is a particularly a problematic area with not a very correct solution. So if we can stratify patients based on the left atrial strain, probably we can offer the preventive therapies or early corrective therapies in these patients. So that is what is the utility of the left atrial strain. And when we did a logistic regression, a multivariate analysis, we found that the left atrial reservoir strain below a value of again 23%. So this was an optimal cutoff where we had got an area under curve of 0.76, which was statistically significant for left atrial reservoir to predict the post-operative AF. As you can see here, the sensitivity is excellent, around 96% with a low specificity, but that is okay. What we need as a screening test is very high sensitivity. So any patient who has got a low left atrial strain, we should focus our preventive therapies like aggressive electrolyte correction, starting of beta blockers early on or for this patient, or prophylactic amiodarone probably in very high risk patients. So these all therapies we can assign to these high risk patients who are likely to develop post-operative. So this was in nutshell 103 patients. We measured left atrial strain in 4 and 2 chamber views. And with the cutoff value of 23%, we got a very good area under curve for this patient. So there are various papers in literature which are available. Ours was on off-pump CABG. This is an isolated CABG on pump. So they have also said that the longitudinal strain does not predict it. So systolic function does not predict atrial fibrillation, but the left atrial parameters like emptying fraction, pump strain, reservoir strain, all these parameters actually, functional parameters of the left atrium actually what were predictive of post-operative AF. So this was a recent multi-center study which is published, I think, in February 2024, and it was a multi-center study. Around 350 patients were enrolled undergoing on-pump CABG with various softwares. It was not restricted to one particular software. So they said that all softwares work well. And post-operative AF-free survival was high in patients who have got a normal left atrial strain. And if you combine it with other risk factors, like those who are elderly, we know that elderly population is at high risk for AF. So if you combine the two factors, age and the left atrial strain, probably you can focus more on these patients. So coming to take-home messages, now we know that we have got various softwares which are available. They are evolving and there are now consensus documents which are available. You can go through those. Believe me, it is not very difficult to do left atrial strain. Although in the beginning it intimidates you, but as you start doing it, you will find its utility definitely. We do it on a regular basis for almost all patients. It has got place in diastolic dysfunction guidelines early on. The British Society has already published about it. So there is large body of literature to support utility of left atrial strain for AF prediction. There are almost 15 studies which are published, and ours, if it's get accepted, it will be one more addition. There are early studies on TE, but they are not fully validated. Probably we need to do something about it. The left atrial strain perioperatively can be very, very useful if you do a particular intervention. So how the patient has responded to it. If you want to see the response to decongestion, diuretics, IVP, so probably all these areas you can use left atrial strain. But if it has to prove in perioperative period, we need a larger studies which are looking at the hard outcomes like major adverse cardiovascular events. So probably we need more studies regarding this. Thank you.
Thank you, Deepak. That was a very, very good insight into the whole thing about left atrial strain. I just want to ask you, you told us about the 3 different types of strain, the reservoir strain, the normal values being around 39%, the pump strain about 17%, and of course the conduit strain. Now, between the 3 strains, which do you think is the most? You pointed out that there's a very good study that pointed out in the paper by Martin et al., I think, which pointed out beautifully about the peak longitudinal LA strain being the reservoir strain, being the most predictive about the outcomes as far as diastolic dysfunction, LVDD, is concerned. And the beautiful algorithms, the 3 scenarios that you showed us by the British Society of Echocardiography. My question to you is, what is the relationship between the volume expansion in a heart failure patient where diastolic dysfunction is very imperative, and whatever said and done, we know that the sensitivity and the specificity of LA strain is low. It's about 74 to 75% and 68% respectively. Now, when you have something which you need a higher sensitivity or at least a specificity for, how do you see in a heart failure patient with preserved ejection fraction, how do you see LA strain telling you about fluid responsiveness, about volume expansion? Let's say I want to give a liter of fluid to my heart failure patient to fill up the LV filling pressures. And if my LV filling pressure is going to be determined by the LA strain, as you beautifully pointed out in your literature and your own studies, I must congratulate you about both the studies. But as you rightly pointed out, what is the relationship between volume expansion, fluid responsiveness, and LA strain? And if there is a relationship, what kind of the 3 LA strain would you think of as being most sensitive?
Yes, madam. Thank you very much for all these comments. Actually, the entire thing about this comprehensive diastolic dysfunction guidelines has been to see for if you have got advanced diastolic dysfunction grade, that is grade 2 and grade 3, which essentially have got higher left atrial pressures. So higher or left atrial and LV EDP, so higher filling pressures. That is what we are most interested in when we are assessing the echocardiography guidelines. So as in the slide I described, there are various caveats for all the parameters that we are presently using, like E by E prime. So E by E prime, it is initially in the initial phase, it is normal. But as the diastolic dysfunction grade worsens, it remains the same. It does not differentiate between grade 2 or grade 3. But in the left atrial strain, the most widely studied parameter is the peak or the left atrial reservoir strain. So that is what is the peak value that has been studied most extensively. But as far as the myopathy or the left atrial fibrosis or left atrial dysfunction as such, if you want to consider, then the booster part of the or the contraction part is what you should be studying. Another very important part that has not been extensively studied is the strain rate during atrial contraction. So if that strain rate is more than -1, so probably you are not dealing with the left atrial dysfunction as such, means not a fibrosis or myopathy. So probably you need still the numbers are evolving, and probably something like below 18 or 19, the peak value, if you have got, then probably you are dealing with high LV pressures, and better not to give too much of fluid. Those patients will not be fluid response.
Perfectly said, because wherever we see the LA strain will reduce if there is some dysfunction happening. But when you are a volume responder in circulatory failure, and this is where we found our study to be very, very good in cardiomyopathy patients, in patients in acute or chronic heart failure, when you're giving volume and there is an increase in the strain, with the increase in the strain, LA strain is the only strain which tells you that this increase in LA strain is not a good predictor of fluid responsiveness. And this is a negative study which we are about to publish. Like your study, I hope we do include it in GCVA. But to put my thoughts to rest, and we could go on and on discussing all this, I have 2-3 very good questions from the people in the chat box. One of them is from one of them says that what is the difference?
Kindly put on your videos. Please put on your videos. Whoever is speaking.
Yes, sir. So the question in the chat box was about atrial fibrillation, whether the left atrial strain is having utility in atrial fibrillation. So yes, definitely there are studies in which left atrial strain is useful as a diastolic dysfunction parameter in AF patients. The only thing is you will not get 3 components of left atrial strain in AF patients. In AF patient, you will not get a booster or a contractile function, because obviously there is no LA contraction which is happening. So you will not get that part. But the peak left atrial strain is very useful in patients with AF as well. And there are studies which are available. Because of paucity of time, I could not include. So those patients who are undergoing this isolation procedures, which are done by structural heart interventionalists, so there is recurrence of AF. So if there is chance of recurrence of AF, can be predicted with the help of left atrial strain. So yes, definitely in cases of AF, it is useful for assessing the diastolic dysfunction.
So one of the caveat, I think Dr. Karthikeyan has asked, what is the caveat in LA strain associated with mitral valve disease? Could you answer that, Deepak? In MR, there's another question on MR and LV filling pressures. So could you answer what is the caveat for LA strain in mitral valve disease?
So actually, I'm not very aware of whether there is any caveat, but I'm aware of a study which has been, which I read some time back, about utility of left atrial strain for mitral repair surgery. So if there is a possibility of a long-term survival, I don't remember it exactly, but there is definitely some literature about mitral regurgitation. I'm not sure about its utility in patients with mitral stenosis, but definitely for patients with MR, it has got a prognostic value.
So it is said that many studies have found that LA strain can be used to predict events of in MS also about atrial fibrillation. So it is there, but again, circulatory failure in in MS patients would want you to be giving less fluids, and this LA, which is already enlarged, LA strain and LA enlargement are synonymous, right? So when you have a very enlarged LA, which is beyond 3.5, normal size of LA is about 2 to 4 centimeters. So let's say you have a 5 centimeter, 5.5 centimeter LA, which is critically enlarged in patients of with stasis in mitral stenosis. LA strain may not have that much of a utility for volume responder as well as for telling you the prediction for diastolic dysfunction, because the stretch that has happened is so much, and therefore the strain felt would be less. That's what we have concluded in one of the study, and a couple of literature papers have come up. Another very good question is that by Dr. Kirti, that LA strain value holds same for diagnosing diastolic function in case of atrial fibrillation in MR as well. I think this very much answers it. Could you answer on MR? It's a very similar question to the MS and the mitral valve that we were answering. You said
Poonam?
you read something on MR. Yes, Dr. Kirti, if you are there.
No, Poonam, I'm Sanjeevani. Can I just...
Yeah, please,
It was a
Sanjeevani, good to hear you.
wonderful session. Deepak, we always look forward to listen to
Thank
you.
you, madam. Thank
And
you.
that
Thank you, madam.
also moderated by Poonam is a cherry on cake.
Thank
And
you.
with
Thank you,
Murlidhar's
Sanjeevani.
presence of Dr. Murlidhar again, so it becomes a very high level speech. About this MR, there
Madam,
is
and you in audience puts lot of pressure on us.
No,
Muralidhar
I
sir
don't
laughing
want to
there, I
put any
know.
pressure.
She
I am
comes
a
on.
very small fish.
Oh,
In
we are
for
talking about
all of you.
we are
humble
talking
people
about
say
LA
that.
pressure, not pressure of Sanjeevani Namdar.
Yes.
I'm a
Yes.
small fish in all this. But only thing is that this MR, MR, there
Yes.
is a biphasic response to in LS strain. Initially, it does increase, but as the MR increases further, there is reduction
Yes.
in. So that is beautifully given. I think it is European again.
Yeah, means as the left atrial myopathy sets in, definitely because of the overstretching, then probably you will start seeing the reduction in the left atrial strain.
About this post-operative AF, beautifully you have shown, and so much you have told us that we have to, again go and read and practice. In this scenario, for our colleagues who are practicing every day, if you are doing a strain pre-operatively, isn't it?
Yes,
So if the strain is less than 23, that is your cutoff, you would start amiodarone straight away in such patients. I mean,
no, madam. We have actually recently completed this study. We have yet to change our protocols for that. But in high risk patients, probably that was the idea. So if you have got very low left atrial strains, so probably there are certain surgical colleagues who like to give the prophylaxis for every patient. So that is not a wise thing probably to do, because the drug is having its own adverse effects.
that
You
is
cannot
why.
continue it. Yeah, you cannot continue it for a longer duration, and it may have immediate hemodynamic consequences also. So the moment you start prophylactic amiodarone IV, if you want, then probably you have to deal with hypotension and significant vasodilatation. So probably what the left atrial strain can do is it can guide you for the therapy for particular high risk patients. So it can identify, although the specificity is little on lower side, specificity is only 50%. So but the sensitivity is good. It is in the range of 95. So you can pick up many false negative patients, but still that is okay. But you can guide the therapy for certain patients based on the left atrial strain.
Also, what you are saying, Deepak, is also a very good thing. If you see the trend in the post-op period, immediate post-op, post coming off bypass, and you have already a patient with AF, and you are wanting to predict the occurrence or recurrence of AF, and see the thromboembolic risk, then the trending in the first 24 to 48 hours post-surgery is a very, very good marker of LS strain. In fact, in most of our cardiomyopathy patients who are coming for cardiac transplant, how to differentiate a very recent trend, and a paper coming up as early as June first week itself in Nature has very beautifully brought out the difference. We don't see Fabry disease and cardiac amyloidosis so much in our country, but we do see a lot of concentric and hypertrophic cardiomyopathy. Now, LA versus RA strain along with LV strain, all causing a complete reduction with an increase in the LV mass and an increase in the LV free wall thickness, are ecodiameter parameters which tell us about primary graft rejection in the first 48 hours post cardiac transplant. And it's a very nice paper. Since we recently did 2 cardiac transplants, I happened to read this paper. There's a lot coming up on RA strain, not from the transthoracic point of view alone, but the new CV Epics and the new machine after Epics from Philips is going to give you the software for RA strain T.
Yes, ma'am. Yes, RA strain is definitely, RA strain is one area which is coming up in big way. Yes, madam. Absolutely, I agree. And, this paper sounds very exciting. Thank you, madam. Thank you.
Yes. So this comparison between LA and RA would be a very good predictor for us in the post-op period to know about all the 4 factors that you beautifully mentioned in your talk. Number 1, LV filling pressures. Number 2, everything about the level of diastolic dysfunction. Number 3, about atrial fibrillation. And number 4, the thromboembolism risk, which is a silent killer, which we don't come to know how a patient goes into cerebral edema because of ICH. And lastly, while we are on that, I think the time is also ticking by, but I want to say that do read LA and RA strain along with LV strain. Not just it is a market gimmick. It is the industry which is giving us the software. It is us users who are putting it on our patients. But while you're in the hands of such gadgets, which a small child learns and does better, why not we as perioperative physicians, anesthesiologists do it for our peri-op patients and have better outcomes and give to the patient the best safety outcomes.
Absolutely.
Thanks a lot,
And with
Deepak.
this,
Thank you.
Yes.
Thank you so
Thank
much.
you, madam.
Thank you very much,
Thank-
Deepak.
thank you,
Deepak,
sir.
very well
Thank-
done.
Thank
In
you, sir.
fact,
Thank you, sir.
somebody commented that you should come onto the screen like this more often, which I totally agree,
Thank
and
you,
I
thank you,
request
sir.
you to be
Thank
with
you,
us
sir.
Totally agree. Totally
Thank you,
agree.
thank you.
frequently. Totally, Dr. Poonam is also agreeing. So there's no option for you. You have to be here with us
Thank you, sir.
now and then.
Thank you, sir.
Thank you so much, and very well done. Very important points were discussed. I would like to thank Dr. Poonam Malhotra for being
Always
with
with
us.
you.
Deepak,
Always with you.
excellent talk. Excellent talk. Very well done. And before we conclude, I request Ritu to play the video about the TE workshop in August. Please join us. It's going to be exciting days in the month of August. Ritu, please play that video.
Sure, sir.
Thank you, Dr. Muralidhar. Thank you, Sanjeevni.
Thank you,
Thank
madam. Thank
you,
you.
Deepak.
Thank you, Raj.
Thank you, Clarnet. Rajiv, thank you.
Thank you very much. See you next Sunday for another exciting session. Thank you very much.
Thank you. Thank you, Dr.
See you soon.
Thank you so much, dear doctors, for sharing such valuable insights. So with all your permission now, we are signing off for today and looking forward to host you again very soon. Thank you. Take care and goodbye.